Hello, and welcome to the Clinical Care Options Oncology podcast. I'm your host, Ryan Topping. Today's episode features an expert discussion focused on current and emerging uses of Regorafenib and TAS-102 in later-line treatment of patients with metastatic colorectal cancer. This episode is part of a larger program consisting of a podcast series focused on treatment options for patients with CRC. During this podcast, Dr. Nilofer Azad from Johns Hopkins University in Baltimore, Maryland, and Dr. Kanwal Raghav from the University of Texas MD Anderson Cancer Center in Houston, Texas, discussed the current use of Regorafenib and TAS-102 monotherapy for patients with colorectal cancer, as well as emerging topics such as the addition of bevacizumab to TAS-102 and combination therapy with Regorafenib and PD-1 inhibitors. Please visit the show notes for this episode for a link to the complete program, including downloadable slide sets and additional expert podcasts. Now, let's get started and hear what Dr. Azad and Dr. Raghav have to say on this important topic.
Well, hello, my name is Nilo Azad, and I'm a medical oncologist at Johns Hopkins University in Baltimore, Maryland. I focus on taking care of patients with colon cancer and rectal cancer, and I'm very excited to be here today for us to talk a little bit about how we might use drugs like TAS-102 or Regorafenib in our patients. And I'm very happy to be here with my partner from MD Anderson, who is going to introduce himself right now as well.
Thanks, Nilo. Hi, everyone. I am Kanwal Raghav. I'm one of the associate professors in GI medical oncology here at University of Texas MD Anderson Cancer Center. One of my clinical and research focus of interest is biomarker-driven therapies in colorectal cancer. But today, I would like to discuss more about the evolving paradigms around Regorafenib and TAS-102. Both of those are approved therapies in colorectal cancer, but there are efforts being made to increase the efficacy and activity of these drugs in later lines. But before we touch on those topics, it would be nice to kind of recap how you actually treat patients in clinic with metastatic colorectal cancer. You know, the landscape is becoming increasingly complex.
Absolutely. So I think we all know that for many years, we treated patients with a 5-FU-based therapy, usually a doublet like FOLFOX or FOLFIRI in the first line, and then we would switch to the other regimen in the second line. And of course, we added a targeted drug as we could. So either bevacizumab or an EGFR inhibitor, depending on people's KRAS status. In the last few years, I think that the tide has been changing with the reports now of multiple randomized trials showing that FOLFOXIRI, the triplet, might really have survival benefit over the doublets. And so there are many of us, including myself, that have moved into using triplet therapy as our first line treatment with both 5-FU, oxaliplatin, and irinotecan being used in the first line. So the reason this matters, of course, for how we're going to use Regorafenib and TAS-102 is that it pulls those regimens up into sometimes second-line therapy if patients progress on FOLFIRINOX or if they want to move into a regimen that might have a little bit better side effect profile. So right now, that's where I think Regorafenib and TAS-102 come into play after the use of those three drugs in whichever way they're given. How have you been giving regimens and sequencing in your practice?
It's becoming widely complicated only because of the advent of more and more molecular subtypes that we're developing therapies against, such as HER2, BRAF, KRAS 12C now. Fortunately, we have the clinical trials available for this, but the reality of the matter is a lot of patients with metastatic colorectal cancer will progress through what is the current standard of care and still retain a reasonable performance status and quality of life to be treated with these third-line treatments or second-line treatments, as you stated, if you're using, triplet cytotoxics up front. I've been generally using these after progression or intolerance to 5-FU, irinotecan, oxaliplatin, and anti-VEGF, anti-EGFR therapies as clinically indicated, because those are the, indications from the CORRECT study and the RECOURSE study, respectively, which put these on the FDA approval list. As far as the sequencing is concerned, we've been using this based on patient preferences, whether they've had, a lot of cytotoxic exposure, what is the state of liver functions, and the toxicity profile that's acceptable to patients, because overall, I feel that the efficacy of these drugs is fairly, similar in that setting. There are some, dose modifications for Regorafenib and TAS-102, which can help make them more tolerable for patients. But as you know, in most cases, it's a stable disease that we can expect out of these. Which brings us to our current topic, which is the ways in which we can improve the efficacy of these drugs. And what I've seen over the past few years is these two large themes evolving. One is combination of Regorafenib or other multi-tyrosine kinase inhibitors with IO to make the proficient mismatch repair or MSS colorectal cancer, which we have still not been able to successfully target with IOs or immunotherapies, to try to see if we can enhance that response. The other theme that I've seen is the combination of bevacizumab or anti-VEGF agents with TAS-102 to increase the efficacy. I know that your group did the initial studies with Regorafenib and pembrolizumab. Would you care to elaborate your clinical experience and what were the findings of that study and the takeaways?
Sure. As I think many people know, the initial study that was really exciting of combining Regorafenib with a PD-1 inhibitor was actually Regorafenib and nivolumab. That was a study that was really mostly done in Asia, but initially reported response rates of 30% and higher, depending on when that trial was reported. There were a couple of different times it was reported. I think that really created significant enthusiasm regarding the idea that this combination could be effective even in a cold tumor like microsatellite stable colorectal cancer. And of course, we were seeing similarly in HCC, hepatocellular cancer, that combination of an anti-VEGF combination with IO also was adding something. So there was justification coming from other tumor types as well, even though those tumors are not considered as cold as colorectal cancer. So, our colleagues in California opened up, I think, the largest trial of this kind of a strategy with Regorafenib and pembrolizumab, and we were lucky enough to participate at Johns Hopkins. That study was just reported at GI ASCO earlier this year. Unfortunately, we really didn't see those kinds of response rates. And this is what often happens with confirmatory studies, and especially when the study population is different, because now it's a more American Caucasian population. So we really didn't see responses in that study. We had, many liver metastasis patients comparatively. We did see stable disease in about half of the patients, but the median PFS was still just 2 months. And the overall survival, did look numerically higher than one would expect. But when you don't have a randomized trial, we don't know what to make of it. So I would say broadly that trial was negative in terms of showing a meaningful benefit of adding Regorafenib to PD-1 therapy in a Caucasian population. So I think that's disappointing, but that doesn't mean that we don't still have other ways that we can continue to target MSS colon cancer. And that's a big area of work that many of us are doing. And you alluded to this before, that I think in colorectal cancer, there probably is not going to be a one-size-fits-all approach to how we get IO therapy to work. We really may need to be looking at these molecular subsets or biological subsets, which are, more sophisticated ways for us to look at subsets of patients, and then determine what the best IO strategy is for these different groups of patients. So there are a lot of investigators working using a lot of different exciting combinations, but I don't know that the Rego PD-1 combination is where I had hoped it would be.
Yeah, I would agree with you. I think, the initial enthusiasm that was generated by the EPOCH 1603 study, the Japanese study, it actually, I saw a lot of off-protocol use of this combination because of that response rate of 30% plus. But there has been, your study with Rego Pembro. There has been a study of Regorafenib with avelumab, which was the Rego Moon study. There was also the expanded version of that study, which was reported by Dr. Marwan Faki, which was the Rego Nivo expanded cohort in 70 patients that were US and only a 7% partial response rate. But one of the things that was common in these studies was they found response rates higher in the subset of patients that presented with lung metastases rather than those with liver metastases. Did you observe any such thing in the Rego Pembro study?
So there did also potentially appear to be a difference in patients that had liver metastasis versus lung metastasis. And I think that data is hypothesis generating, is how I would describe it, because this phenomena of the idea that lung and liver might have a different tumor microenvironment and accordingly different benefit from IO therapy has been hinted at in many different tumor types, not just in colorectal cancer. But I don't know that we have the data to say this significantly. And I think the bigger lesson from the Rego plus PD-1 studies is that when you have small trials that show these trends, often in later studies that are larger and more definitive, they don't bear out even when it comes to these subsets. And so I feel very reticent to go down that path without just saying that I think that we really need to study it in a bigger trial rather than, when we pull out these pieces, it's really for us to find ways to try to find how the strategy might still work. But then the real work has to be done in actually testing it. Maybe I've just had my heart broken one too many times.
So, I know that despite these initial discouraging results, there are a slew of studies that are combining one or the other TKI with immunotherapy in colorectal cancer. The one that comes to my mind is the LEAP combination with lenvatinib and pembrolizumab. Just wanted to see what your thoughts are. I know that the larger studies are ongoing, but the initial response rates were about 20% or so in colorectal cancer. And I think that there are other studies with cabozantinib ongoing. So any last thoughts on that?
Yeah, I mean, I really hope one of them is positive. I think that there's a couple of phase 3 trials ongoing now with that kind of TKI plus PD-1 strategy. We also, speaking of heartbreaks, MBLAZE, where we did MEK plus PD-1 in phase 1, that was also close to a 20% response rate. And when they went into phase 3, it was a negative trial. And so we just won't know till those trials are reported. But there's enough preliminary data in phase 1, phase 2 to do the testing. And so I'm very glad it's being done. But I really think that what we've learned is that until the trial is reported, you really don't know which way it's going to go because of how many times that it's gone the opposite direction of what we thought.
So let's switch gears for a little bit, and I think for a third line or second line, or I would say some of these later lines of therapy, it seems like at least in the clinic today, you would be using regorafenib as a single agent and not really any combinations, unless it's on a clinical trial, right?
Agree.
So then we come to the next drug here, which is the TAS-102. I've heard conflicting opinions, similar studies and similar experiences with combination of TAS-102 plus, bevacizumab, sort of in line with the theme of continuing VEGF inhibition, as has been done for second-line therapy combined with chemo, which has shown improvement of overall survival. So any thoughts on the preliminary data supporting TAS-102 and bevacizumab combination?
Yeah, so I'm very enthusiastic about combining bevacizumab with TAS-102, and that is actually how I administer TAS-102 off protocol in my practice. I think I'm convinced because I'm more convinced about that benefit for two reasons. One, because it was a randomized trial that showed this benefit, and the TAS-102 alone arm did as you would expect. So it seems like an appropriate historical control in terms of the magnitude of benefit that was seen with the single agent versus the combination. So we have the phase 2 data, and we have to determine whether this changes how we treat our patients or not. But because of those two features of the randomized phase 2 study, I have moved to that in my practice. If the trial had not been randomized and we saw the same magnitude of benefit of the doublet, I would not have moved to the doublet. But because it was a randomized study, that really did compel me when I was making choices with my patients to do that. What have you been doing?
So we've been using, regorafenib and TAS-102 sort of as single agents for the time being. Although even within our group, there can be differing opinions, and I think the whole aspect of the CTAS Force study and then the Denmark study, which was the randomized study that you alluded to, really happy to see that, difference of, progression-free survival and also, to a certain extent, the overall survival. One of the key things that I thought was a drawback of the study, apart from, of course, the sample size, was the fact that PFS was the primary endpoint and it was like sort of investigator assessed, not really centrally assessed. Because if you look at the CTAS-4 study, which was the Japanese study that started this all, there was a big difference of progression-free survival just between central and investigator assessment, right? It was like 3.7 months for central review and 5.6 months for investigator review. So I really hope that they would have done an independent blinded central review, especially for an endpoint like progression-free survival. The second reason why I was less impressed by the study results was because it really didn't change the partial response rate at all. And I would really have liked to see some extra partial responses with combination, although it can be understood that both of these are not really cytocidal agents. So it is quite possible that they just increase it through disease control rate. But the final, sort of nail in the coffin, at least for me, is the fact that the population had about 20% rate of patients that had never progressed on a prior bevacizumab-based treatment. And that's just not the kind of population that we see at least in our center. I mean, almost everyone gets some sort of anti-VEGF therapy. Most cases, people actually get 2 anti-VEGF therapies. And, in most cases, in the trial at least, I think 50% of the population had received second-line anti-VEGF therapy and 30% had only received first-line anti-VEGF therapy. So I feel that the theme of continuation of the VEGF could possibly have changed the results. And if you look at the subgroup analysis, granted the subgroup analysis are of course not powered to answer such question, but if you look at the hazard ratios for patients that were pre-treated with bevacizumab versus not, the hazard ratios definitely trended more towards the center when you compare the two arms. To add to it, there was also some more grade 3 neutropenia. So again, I have not been using this in my clinical practice. I still use TAS-102. There are 2 main reasons apart from the things that I have mentioned already. We actually have a clinical trial where we're looking at ctDNA guided therapy. And that ctDNA guided therapy is only for FDA approved indications, and thereby Regorafenib and TAS-102 are on that, and we've been treating patients on that. And the aim of that study is to figure out whether early assessment of ctDNA can actually weed out the early progressors for these lines of therapy. And the other reason is because, like you said, the randomized phase 3 trial of this combination is now ongoing, which is the Sunlight trial, which is, again, TAS-102 with bevacizumab versus TAS-102 as a single agent. It's a large trial, about 800 plus patients, about 500 plus patients, and OS is the primary endpoint. So I'm actually very excited about that trial and looking forward to the results of that trial before incorporating this in routine practice.
Yeah, I think if a patient has a clinical trial option like what they have at your institution for this line of therapy, it absolutely makes sense to be studying something. I think I'm somebody, when Fire 3 was reported, the EGFR study that showed benefit for EGFR over bevacizumab in the first line, I used that regimen for a year until 80405 was reported, which then that was the OS data, and it didn't show that there was a difference. And so I tend to be an early adopter of these regimens in randomized phase 2, but I'm very receptive to understanding that eventually if the definitive trial is different, then I'll walk it back at that point. Right now, what I'm doing is trying to make the best decision for our patient at this time when the data is still evolving. But I think all of your criticisms of the study are completely valid.
Yeah, I mean, I agree. And I think, the Sunlight trial should enroll fairly quickly and we should have these results. And I do feel that the OS is actually a really good endpoint for this kind of therapy. Which brings me to another point is, have you been selecting patients for Regorafenib versus TAS-102 bevacizumab combination based on any predictors, whether it is clinical, molecular, or pathological in nature?
No, I've basically been making the choice between the two based on what prior toxicities that patient has had on their prior therapy. So a patient who's really struggled with cytopenias, I would opt into regorafenib over a TAS-102 based regimen, as we know that TAS-102 results in more challenges with neutropenia than regorafenib does. And then in almost everybody else, I'll move with TAS-102 first. So overall, the quality of life on TAS-102 has been better for my patients. And I also, in the initial report of the TAS-102 study where we saw the maintenance of performance status, I thought that was actually a beautiful endpoint to incorporate into a phase 3 trial for a late line patient population. So that has been part of the reason that I generally prefer TAS-102 unless someone has struggled with cytopenias.
Yeah, I mean, I guess, you're absolutely right. There is really no clinical, pathological, or molecular predictors right now which can, move patients into one of these arms. And sequential therapy is the way to go. Well, thank you very much, everyone, for listening. And we hope that this session has helped you make better informed decisions to take care of your patients with metastatic colorectal cancer.
Thank you very much, Dr. Azad and Dr. Raghav. And thanks to you, the listeners, for joining us. As a reminder, to view the full program and to download the slide set associated with this discussion from the Clinical Care Options website, please click on the link in the show notes. As always, thanks for listening.